I just want to give you a few highlights regarding the status of the patients we are taking care of as at now. As at today, we have 214 patients spread across various hospitals, of course, from the coast to the western part of the country. Out of these 214, it's only one patient who is in critical care under ventilatory support at the Kenyatta University Teaching, Research and Referral Hospital. The remaining 213 patients are in stable condition, and we are hopeful that they'll continue to do well, and therefore going forward we'll have more discharges coming from our healthcare facilities. I'm sure you must have heard of the news from the United States regarding the new drug, remdesivir, for treatment of severe coronavirus disease. This is a medicine that was initially tried for Ebola virus treatment and was also used for treatment of other coronaviruses like the Middle East respiratory syndrome and the SARS, severe acute respiratory syndrome, whose outbreak was reported in 2003 in Hong Kong. This medicine, a trial was done in the United States involving 1,063 cases, and this was a good trial because the caseload was good, more than 1,000 people, and the primary endpoint was the recovery in terms of either stoppage of use of supplemental oxygen for critically ill patients or the time for discharge. And during this study, 31% of the 1,063 people were able to go home within 11 days, compared to the other arm who received the normal treatment. Based on this, the Federal Drug Administration Authority in U.S. has decided to register this medicine for treatment of coronavirus disease 19. However, this is not to point out that now we have a cure, because if you look at the time frame, it's only 15 days for those who receive normal treatment versus 11 days for those who receive remdesivir. Therefore, this is not a silver bullet, though it has been approved, but the other shortcoming of this medication is that it can only be given as an infusion through an injection, so there's no oral formulation, and is also relatively expensive. For our cases, because most of our cases are mild asymptomatic cases, it could be deployed, but to a small fraction of our patients. Of course, we still continue to pursue the use of other medications, including favipiravir, also called Zavigan from Japan, the antiretroviral medicines that have been tried, that is lopinavir, ritonavir, or Kaletra, as commonly known, the use of chloroquine, hydrochloroquine, which again has also been prioritized by the U.S. government. And of course, is now available locally in case we need to deploy it for our patients. So that is in terms of the treatment landscape, how it looks like. Still no cure, despite this encouraging news. For testing, you have heard of this case of Senegal where they used the rapid test kits. And the rapid test kits from Senegal are based on antibodies. Antibodies are basically proteins that our bodies produce in response to an insult or an antigen or a foreign body. And the first antibody that your body produces if you get exposed to a virus, say measles or COVID-19, is called IgM. The second antibody, which is produced much later, after usually 2 weeks or before, is called IgG. So the one of Senegal is based on IgM. But the pitfalls of these rapid test kits is because, one, you tend to produce the antibodies after about 2 weeks. Therefore, you lose significant opportunity of 14 days where you could be able to trace, isolate, and quarantine people, and therefore stop further transmission of the infection. So that is one big limitation of the rapid test kits. Number two, the rapid test kits are not selective. There are very many types of coronaviruses. So even if you have the coronavirus that causes a mild cold, the rapid kit could interpret it as COVID-19. That is what we call in science a false positive. And therefore, you will be diagnosed as corona virus disease 19 positive, yet you have the simple corona that causes a cold. Number 3 is that if you are immunosuppressed, like if you have HIV infection, or you are malnourished, or you have a serious infection like TB, your immune response is subdued, and therefore you tend to produce less antibodies or no antibodies at all. In that case, if you put you through that test, it will come out negative, yet you could be positive for COVID-19. And finally, regarding the rapid test kit, is because even if you have the antibodies, evidence has not shown that those antibodies will protect you from reinfection. However, these are good diagnostic equipment that can be used for research purposes, like in Cambridge, and also for carrying out what we call seroprevalence surveys, or you want to find out the spread or the incidence of a disease in a community, or the prevalence of a disease in a big community. I also wanted to emphasize a bit on the cases from Kawangware, as Madam CS has alluded to. There are 20 cases from Kawangware. 12 of these cases can be traced back to one single individual. And this single individual used to work with us at the Emergency Operations Center. This single individual passed the infection over to 6 primary contacts. Out of these primary contacts, there are 5 secondary contacts. So if you draw that tree, there are 12 people linked to this particular case. If you look at the case of Kilifi, the index case had 5 primary contacts, 1 secondary contact, and 1 tertiary contact. And of course, we continue to do surveillance because the 14 days mandatory period for incubation has already passed. So you cannot be able to tell how many people one person can be able to pass the infection to. And why am I saying this? Because this is important, because then it is the reason that we talk about quarantine and isolation. That quickly, if we test you, we need to move you into the isolation unit so that you don't stop growing these branches. And for those who test positive, of course, we also move you to the isolation site. The others who have not been tested, of course, are kept in quarantine, therefore trying to stop the transmission. And that is basically what leads to a flattening of the curve. Finally, I wanted to share with you the donation that we received from one of our many partners who have supported the ministry. One is the Jack Ma Foundation. I have a table here with me regarding the quantities of whatever was donated, what has been distributed, and what is still in stock in our KEMSA stores. Like, for example, the test kits were a total of 208. If you multiply that by 80, you get about 17,000 test kits. Remember, if you test you and you test positive, at a minimum, you will require 3 tests at a minimum. The first test, the index test, that determines whether you are positive or negative. If you are positive, then you require another second test after 14 days. If that test is negative, you require another test after 24 to 48 hours. So if you divide this number of kits by 3 on average, then you find that we had about 5,000 to 6,000 test kits. And therefore, anytime we report that we have a given number of test kits, remember each individual at a minimum will require 3 tests. So always divide it by a minimum of 3. Of course, we also received viral transport media, 18,900 pieces, all which have gone to various laboratories, various face masks which have all been distributed, medical disposable protective clothing, 1,100 pieces distributed. I can be able to share this with you. So in a nutshell, based on what I've been able to share with you, is that we are not out of the woods yet.